Dear students, now I'll be discussing a topic of the adrenal gland disorder, that is pheochromocytoma. Right, that is pheochromocytoma. Alright, so even this particular pheochromocytoma, let me tell you, I will teach this particular entire topic from the basics, right? I'll take you through the physiology, pharmacology, pathology, and then I'll take up the internal medicine part of your pheochromocytoma. Now what is this pheochromocytoma? Pheochromocytoma, remember, it is the tumor of adrenal medulla. Right, it is a tumor of the adrenal medulla. Now within the adrenal medulla, you have what is called as the chromaffin cells. Right, you have what is called as the chromaffin cells. This pheochromocytoma, right, this pheochromocytoma, it is a tumor originating from, right, tumor originating from chromaffin cells of tumor originating from the chromaffin cells of the adrenal medulla. Now, a point what you should remember here is, remember this particular chromaffin cells, that is adrenal medulla, right, they will produce the two important hormones, that is not two important hormones, they produce what is called as the catecholamines, right, catecholamines. And these catecholamines, they include epinephrine and as well as norepinephrine, right, epinephrine and as well as norepinephrine. You take epinephrine, in 80% of individual, the adrenal medulla, it will produce catecholamines, majority of it is your epinephrine, right, majority of it is your epinephrine, whereas only 20% it will produce norepinephrine, right, whereas only 20% it will produce the norepinephrine. That is the normal physiology what I am trying to talk about. Whereas we have a question in this way, you see this question now, pheochromocytoma, right, pheochromocytoma predominantly secretes epinephrine, norepinephrine, dopamine, dopa. This is the question here. Remember, the answer here is pheochromocytoma predominantly secretes the norepinephrine, right? Even though adrenal medulla physiologically it produces excess amount of epinephrine, but pheochromocytoma, it will predominantly secretes the norepinephrine, right? So this is a very important question, okay? So pheochromocytoma, it predominantly secretes norepinephrine, all right? Next, now you take this particular norepinephrine, the metabolite of your norepinephrine is vanillyl manlic acid, right? The metabolite of the norepinephrine is the vanillyl manlic acid. This is the main hormone which is being secreted. Next, we have another terminology which is called as malignant pheochromocytoma. right? Another terminology which is called as the malignant pheochromocytoma. Now, you take this malignant pheochromocytoma. Malignant pheochromocytoma is the one where besides epinephrine, right, besides epinephrine and as well as norepinephrine, along with this, dopamine is also being produced in these patients with the malignant pheochromocytoma. Now, if you take the metabolite of dopamine, the metabolite of your epinephrine and norepinephrine is your vanillyl mandelic acid. Whereas, if you take the metabolite of dopamine, that is, metabolite is homo-vanillinic acid. Right, the metabolite is the homo-vanillinic acid. So, in case of malignant pheochromocytoma, epinephrine, norepinephrine and as well as dopamine, all these substances are increased. Right, all these substances are increased. Next, we have another terminology which is called as paragangliomas. Right, paragangliomas. Now, remember, you should remember a point that this particular chromaffin cells, they are not only present within the adrenal medulla. These chromaffin cells, they are also present within the extramedullary region as well. The chromaffin cells, they are also present within the extramedullary region as well. The tumor which is originating from the chromaffin cells which are present outside the adrenal medulla, they are called as the paragangliomas. Alright. So, paragangliomas, they are extraadrenal tumors. Right, extraadrenal tumors of sympathetic or vagal vagal ganglion cells. Right, vagal ganglion cells. And this paragangliomas, remember, they arise from the carotid body. Right, because they arise from the carotid body, they are called as they are called as the carotid body tumor, or they are also called as the potato tumor. Right, they are also called as the potato tumor. Is that clear? Now there is one important multiple choice question here related to your biochemistry. What is the amino acid from which your epinephrine and norepinephrine are being synthesized? Remember, it is the amino acid tyrosine from which the synthesis of epinephrine and as well as norepinephrine is being formed. Right, and this pheochromocytoma, this pheochromocytoma, remember, because it is originating from the chromaffin cells of the adrenal medulla, this pheochromocytoma, this is also called as chromaphenoma. Right, this is also called as chromaphenoma, and this predominantly secretes what? Norepinephrine. Right, and remember, you take your extraadrenal tumors, they are called as what? Paragangliomas. Right, these paragangliomas, they are present either in the sympathetic chain or they are present within the vagal ganglion. Right, they are present within the vagal ganglion. Now remember, this particular pheochromocytomas which are producing predominantly norepinephrine and the extraadrenal tumors, you need to know what is the location of the paragangliomas. Right, you need to know the location of this particular paragangliomas. Now, if you take the location of the paragangliomas, based on the location, like a question can be asked like this. This we already have discussed, predominantly secretes what? Norepinephrine. Yeah. If you take the pheochromocytomas, they arise from what? Non-endocrine cells of the adrenal cortex, non-endocrine cells of the adrenal medulla, neuroendocrine cells of the adrenal cortex, neuroendocrine cells of the adrenal medulla. Remember, pheochromocytomas, they originate from the neuroendocrine cells. It is not the non-endocrine cells, it is the neuroendocrine cells of the adrenal medulla. Now, a question based on the location of the paragangliomas. Now, you see here, we have a question like this. Right, we have a question like this, that is, what is the most common extra-adrenal site of a pheochromocytoma? Renal hilum, mediastinum, urinary bladder, organ of Zuckerkandl. Right? Now let me tell you the various locations where the paragangliomas can be present, and let me come back to this particular question again. You see here the location of the paragangliomas. Remember, the location of the paragangliomas, number one, they are present in the abdominal para-aortic area. Right? The percentage of the paragangliomas location in the abdominal para-aortic area, it is nearly around 75%. And this particular paragangliomas, they can be present within the urinary bladder, that is 10%. And this paragangliomas, they are present in the thorax, that is 10%. This paragangliomas, they are present in the head and neck, 3%. And this paragangliomas, they are present in the pelvis, that is 2%. That is 2%. Okay. So these are the location of the paragangliomas, right? Location of the paragangliomas. Is that clear? Now, if you go back to the question, what is the most common extra-adrenal site of the pheochromocytoma? Renal hilum, mediastinum, urinary bladder, organ of Zuckerkandl. Remember, the answer here is your organ of Zuckerkandl. Why? What is organ of Zuckerkandl? Remember, organ of Zuckerkandl, it is the chromaffin body, right? It is a chromaffin body which is present in the abdominal para-aortic area. Right, it is a chromaffin body which is present in the abdominal para-aortic area. So this is a very important point regarding your organ of Zuckerkandl. So this is the most common site for your extra-adrenal site, pheochromocytoma. Alright. Now after having discussed about this, now let me tell you the another very important points, that is the clinical features. Now on the clinical features, this is how the questions can be asked. All of the clinical features of the pheochromocytoma except increased hematocrit, orthostatic hypotension, low cortisol levels, impaired glucose tolerance, right? Now, let me discuss the clinical features and we will come back to this question again. So, until now we have discussed that what is pheochromocytoma and what are your paragangliomas. The most common site for paraganglioma is the organ of Zuckerkandl. So these points we have discussed. Now we need to discuss the clinical features of the pheochromocytoma, and later on we will come back to this question. Now remember, the clinical features in these patients with the pheochromocytoma is mainly because of increase in the epinephrine and as well as the norepinephrine. Right? So one by one we will discuss. We will discuss what will happen once this epinephrine and norepinephrine increases and what will be its effect on the cardiovascular system. Right? What will be its effect on the cardiovascular system. You take epinephrine and norepinephrine. Right? If you take this epinephrine and norepinephrine, remember epinephrine and norepinephrine, they have positive inotropic effect. right? That means they will increase the force of contraction. So in case of pheochromocytoma, right, in case of pheochromocytoma, the inotropicity grossly increases, so there is increased force of contraction compared to normal. Whereas you take on the heart rate of the individual, epinephrine and norepinephrine, you take the basic physiology, they are positive chronotropic effect, right? They have positive chronotropic effect. If you take the chronotropicity, that is, they will increase the heart rate of the individual, right? They will increase the heart rate of the individual. Now you take in pheochromocytoma, the heart rate abnormally increases because of gross increase in your epinephrine and norepinephrine, so due to which they will have tachycardia, and as well as they will have what is called tachyarrhythmias, right? Tachyarrhythmias. And because of this tachycardia and as well as tachyarrhythmias, the clinical features what they will have is they will suffer from what is called as the palpitations, right? They will suffer from what is called as palpitations. Next, you take this epinephrine and norepinephrine, they have positive dromotropicity. That is, these epinephrine and norepinephrine, they will increase the velocity of conduction, and they will also have positive bathmotropicity. Right, positive bathmotropicity. That is, these epinephrine and norepinephrine, they will increase the excitability, right? They will increase the excitability. So remember, because of increased velocity of conduction and because of increased excitability in pheochromocytoma, wherever there is excessive increase in epinephrine and norepinephrine, so there is so much increase in velocity of conduction and as well as excitability, and that will result in arrhythmias. Right, that will result in arrhythmias. That is your either ventricular tachycardia or ventricular fibrillation, or it might be your atrial fibrillation. So due to which these individuals, they will have palpitations as the clinical manifestation. Next, the other important thing what you should remember is, you take the physiological action of epinephrine and norepinephrine on the blood vessel. On the blood vessel, epinephrine and norepinephrine, it will cause vasoconstriction, right? Vasoconstriction by acting on the alpha-1 receptors. Now in pheochromocytoma, there is gross increase in your epinephrine and norepinephrine, so due to which what will happen is, right, due to which what will happen is, there is very severe vasoconstriction for which they will suffer from what is called as hypertension. Now if you take this particular hypertension, right, is of two types. One, you have sustained hypertension, and then you have paroxysmal hypertension. Right, sustained and as well as paroxysmal hypertension. Sustained hypertension is seen in case of 60% of individuals. Paroxysmal hypertension is seen in case of 40% of individuals. The word paroxysmal means sudden. Right? So there is sudden shoot of increase in the blood pressure, that is called as the paroxysmal hypertension. Right? That is called as paroxysmal hypertension. Next. Now a point what you should remember here is, because of this particular hypertension, the clinical feature what you will have is headache. The clinical feature what you will have is headache. Remember, the most common clinical feature in pheochromocytoma is headache, right? This is a clinic MCQ here, and you take the most common sign in pheochromocytoma, it is your hypertension. Most common clinical feature is headache. The most common sign is what? The hypertension. Alright, next. Now the other important thing what you should remember here is, remember you take the effect of epinephrine and as well as norepinephrine on the myocardial activity. So what is it doing to the myocardial activity? The myocardial activity is increased by your epinephrine and norepinephrine. In pheochromocytoma, in pheochromocytoma, the myocardial activity grossly increases. But at the same time, what is your epinephrine and norepinephrine doing to your coronary blood vessels? Right? What is it doing to your coronaries? To the coronaries, it is causing vasoconstriction. Right? To the coronaries, it is causing vasoconstriction. Now, a point what you should remember here is, because the myocardial activity is increased in pheochromocytoma, but there is vasoconstriction of the blood vessels, what will happen to the myocardial blood supply? Myocardial blood supply will be reduced. Right? Myocardial blood supply will be reduced. Now, once the myocardial blood supply is reduced, but myocardial activity is increased, these myocardium, it suffers from angina and myocardial infarction. So a point what you should remember here is, these patients, they will have angina and myocardial infarction even in the absence of even in the absence of the coronary artery disease. Even in the absence of the coronary artery disease. Is that clear? Next. The other important point is that you take the epinephrine and norepinephrine on the BMR of the individual. Remember, epinephrine and norepinephrine, it will increase the basal metabolic rate of the individual. But you take in patients with pheochromocytoma, there is excessive increase in epinephrine and norepinephrine. So what do you think will happen to the metabolic activity? There is increased basal metabolic rate. The metabolic activity increases. So due to which the clinical features will be, these individuals, they will have profuse sweating, they can have weight loss, they will also have elevated body temperature. They will also have elevated body temperature. So these are the clinical features what you see in the patients with the pheochromocytoma. Is that clear? Next. Now let me tell you on the carbohydrate metabolism. Let me tell you on the carbohydrate metabolism. Remember, on the carbohydrate metabolism, what will be the features? First, you should know basic physiology, what epinephrine and norepinephrine does to the glucose metabolism. Remember, epinephrine and norepinephrine, they have anti-insulin action, and not only that, this epinephrine and norepinephrine, it also increases glycogenolysis. It has anti-insulin action, and not only that, it also increases the glycogenolysis. Now, in case of pheochromocytoma, this particular above activity is increased. That means they will have profuse anti-insulin action and there is increased glycogenolysis. What is glycogenolysis? That is the breakdown of the glycogen to the glucose. So due to which these individuals, they have increased glucose levels in the blood, and that results in impaired carbohydrate tolerance. right? That results in impaired carbohydrate tolerance. Is that clear? Next. Now, apart from this, there are some other manifestations as well. Right, you see the other manifestations. The other manifestations in these individuals is, now because of very severe vasoconstriction, what is happening to the plasma volume of the individual? The plasma volume of the individual reduces. Because the plasma volume of the individual reduces because of very severe vasoconstriction, what will happen to the hematocrit? The hematocrit increases. Right, the hematocrit increases. And not only that, because of decrease in the plasma volume, right, because of decrease in the plasma volume, what will happen is, whenever these individuals, they get up from the supine position or the sitting position, there will be a postural drop of the blood pressure because of decrease in the plasma volume, and due to which these individuals, they will have what is called as orthostatic hypotension. Right, due to which they will have what is called as orthostatic hypotension, right? Now, these are the other important manifestations. Why? These are due to because of decrease in the plasma volume. Okay, this is a very important point. Next. Now, the other important thing is, these individuals with the pheochromocytoma, they can also have hypercalcemia as well, rarely. Now, these are the clinical manifestations in patients with the pheochromocytoma. Now, there is what is called as classic triad of pheochromocytoma. The classic triad of the pheochromocytoma is, so if you take the very important feature, that includes number 1, these individuals, they will have episodic headache, right? Why is this due to? This is because of hypertension. And the other important thing is, these individuals, they will have palpitations, right? Why is this due to? This is because of tachycardia, right? This is because of the tachycardia. And the other part of the triad is sweating. And this particular profuse sweating is because of increased basal metabolic rate. Right? That is because of increased basal metabolic rate. So this is the triad in pheochromocytoma, right? Episodic headache, palpitations, and as well as the sweating. Now you should remember what is called as the rule of 10 in pheochromocytoma. Right? Even though nowadays it is being rarely followed, but you should know what are the components of the rule of 10. Remember, 10% of these tumors, they are malignant. 10% of the tumors, they are bilateral. 10% of the tumors, they have familial tendency. 10% of the tumor, they are seen in children. Right? 10% of the tumors, they are seen in children. And so this is nothing but your rule of 10. Right? This is nothing but your rule of 10. Next. Now, a point what you should remember here is, now this epinephrine and norepinephrine, where do they act? They act on the alpha and as well as the beta adrenergic receptors. Right? They act on alpha and as well as beta adrenergic receptors. Now this particular alpha and beta adrenergic receptors, they will be having paroxysmal stimulation. That means they will be having sudden stimulation or abrupt stimulation because of release of the epinephrine and norepinephrine abruptly. So because of this paroxysmal stimulation of alpha and beta receptors, you need to remember there are following features. They can have paroxysmal hypertension, sudden increase in the blood pressure. They can have pounding headache, right? That is because of increase in the blood pressure of the individual. They can have excessive perspiration, right? That is because of increased basal metabolic rate. And they can have palpitations, right? That is because of excessive increase in the heart rate of the individual. They can have pallor as well. That is because of very severe vasoconstriction, the cutaneous blood supply will be reduced and they can have this particular pallor. So these are the 5 P's which will occur due to paroxysmal release of your epinephrine and as well as the norepinephrine. Now you come back to this question here now. All are the clinical features of the pheochromocytoma except increased hematocrit will be there. Why? What is the reason for the increased hematocrit? That is mainly because of decrease in the volume of the plasma within the blood vessel. And even orthostatic hypotension is also because of decrease in the plasma volume within the blood vessel. And impaired glucose tolerance will be there. That is because of anti-insulin action and as well as the glycogenolysis. In these individuals will not have low cortisol levels. Low cortisol levels is a feature of your Addison's, not your pheochromocytoma. Pheochromocytoma is nowhere related to your corticosteroid levels. So the answer here is C. Right? The answer is C. That is your low cortisol levels. Now, after having discussed about the questions on the clinical features, the questions can be asked in a following manner in the investigation. The investigation of choice in pheochromocytoma is CT scan, urinary catecholamines, MIBG scan and urinary calcium measurements. Now, a very important point what you should remember here is, so let me discuss the investigations. Always and always, once you confirm the endocrine disorder by your chemical analysis, then you have to go with the imaging studies, right? Then you have to go with the imaging studies. Now you have a screening test here first. So whenever you have the suspiciousness of the pheochromocytoma, the screening test, it includes 24-hour urine, fractionated metanephrines. Right? Now, apart from this 24-hour urinary fractionated metanephrines, we also have fractionated catecholamines as well. But remember, between these two, that is fractionated metanephrines and as well as fractionated catecholamines, it is your fractionated metanephrines which is very important. Right? It is your fractionated metanephrines which is very important screening test. Now, once you confirm by your screening test that fractionated metanephrines are increased, then you have to do the investigations within the plasma. That is plasma fractionated metanephrines right? Plasma fractionated metanephrines, they are increased. Okay. So now if you see the investigation of choice for screening, right? Investigation of choice for screening, it is your 24-hour urinary fractionated metanephrines. All right. Now you take this particular metabolites, that is fractionated metanephrines, you take the vanillyl malic acid. Normal levels of your vanillyl malic acid in an adult individual, if you take, it is less than or equal to 6 milligrams per 24 hours. This is the normal levels of VMA, vanillyl malic acid. But in these individuals with the pheochromocytoma, the vanillyl malic acid levels per 24 hours, it will be more than 6 milligrams per 24 hours. Okay, so this fractionated metanephrines sensitivity and as well as specificity, it is higher compared to that of the catecholamines. Right, sensitivity and specificity is good compared to that of the fractionated catecholamines within the urine or within the plasma. Now, a point what you should remember here is the confirmatory test is being done by the plasma metanephrines. Now remember, if the plasma metanephrines, right, if the plasma metanephrines, if they rise more than 4-fold of upper limit, right, if they rise more than 4-fold of the upper limit, it is diagnostic of pheochromocytoma. Right, this point is important, right, more than 4-fold, that is diagnostic of pheochromocytoma. Now, if the rise, right, if the rise is less than 4-fold, then the individual has to undergo what is called as Clonidine suppression test. Right, the individual has to undergo the Clonidine suppression test. Right, now you see what is the dosage of the Clonidine in the Clonidine suppression test will be the multiple choice question. Now you see this question before that. So the investigation of choice in pheochromocytoma is what? The investigation of choice will be your urinary catecholamines. Alright. Actually the answer should be urinary metanephrines, but urinary metanephrines are not there. So you can go with the urinary catecholamines. Okay. That will be the investigation of choice for the screening. Now only and only when the screening test and the confirmatory test is positive, that is the point when you have to go with the imaging studies. And I'll tell you which is the imaging studies which is best and which has more sensitivity and as well as the specificity as well. But before that, right, before that you should know, right, before that you should know what is this Clonidine suppression test and what is the dosage of the Clonidine. So the question you see here, dose of the Clonidine in suppression test done for pheochromocytoma is 0.3 milligrams, 10 milligrams, 100 milligrams and 200 milligrams. Now when you are doing this Clonidine suppression, before that let me tell you what is Clonidine actually, right. So if you take the Clonidine, it is an antihypertensive. Now what is the mechanism of action of this particular antihypertensive effect? Remember this Clonidine, it is centrally acting alpha 2 sympatholytic drug. Right, centrally acting alpha 2 sympatholytic drug. Now what will happen because of this? Let me explain you. Now you see epinephrine and norepinephrine is being produced by your adrenal medulla, and epinephrine and norepinephrine, they are also the neurotransmitters of the sympathetic nervous system. Right, now for example, if there is excessive sympathetic discharge, what will happen to your epinephrine and norepinephrine? The epinephrine and norepinephrine levels will be increased. Okay. Now you take in case of pheochromocytoma, right, in case of pheochromocytoma also the epinephrine and norepinephrine levels, they are increased. Right, in pheochromocytoma also the epinephrine and norepinephrine levels are increased. Is that clear? Now you should know that, you should remember a point here that epinephrine and norepinephrine whichever has been increased, is it because of excessive sympathetic discharge or is it because of the pheochromocytoma? If it is because of the pheochromocytoma, the epinephrine and norepinephrine will be increased more than 4-fold. There is no doubt in that. We can diagnose pheochromocytoma. But if the increase in epinephrine and norepinephrine is less than 4-fold, now there is a problem here, right? Now there is a problem here. Is it because of the pheochromocytoma or is it because of excessive sympathetic discharge? Now, to differentiate this, what you have to do is, you have to give 0.3 milligrams of clonidine. Right, you have to give 0.3 milligrams of clonidine. Whenever you give this 0.3 milligrams of clonidine, what this clonidine will do is, clonidine will suppress the excessive sympathetic discharge. But this clonidine, it has no effect on the pheochromocytoma. Right, it has no effect on the pheochromocytoma. This is a very important point what you should remember here. Right, that means what the clonidine can do, clonidine can suppress the excessive epinephrine and norepinephrine release from excessive sympathetic discharge, but not the pheochromocytoma. So whenever you give clonidine, in spite of that, if the epinephrine and norepinephrine is increased, in spite of giving clonidine, if the epinephrine and as well as the norepinephrine, if it is increased, this is suggestive of that the patient is having pheochromocytoma. Right, this is suggestive of the pheochromocytoma. Is that clear? Now, but whenever you give epinephrine and norepinephrine, right, whenever you give epinephrine and as well as norepinephrine, if there is decrease in the, whenever you give clonidine, if there is decrease in the epinephrine and norepinephrine, then it is because of excessive sympathetic discharge. But in spite of giving clonidine, if the epinephrine and norepinephrine is still high, it is your pheochromocytoma. So remember, whenever you give clonidine, if there is decrease in the epinephrine and as well as norepinephrine, this is because of increased sympathetic nervous system discharge. So the dosage is very important. That is a multiple choice question. That is your 0.3 milligrams is your dosage. Now let me tell you the other investigations here. So once you do chemical screening and confirmation, you have to do the imaging studies. If you take the imaging studies, right, if you see the imaging studies, the CT or MRI of the abdomen is very important. These investigations, they have excellent sensitivity, but it lacks specificity. Right? These investigations cannot detect if the tumor size is less than 1.5 centimeters. Right? They cannot detect if the tumor size is less than 1.5 centimeters. Now what is the other investigations? We have what is called as MIBG scan. That is meta-iodo benzyl guanidine test. Right, meta-iodo benzyl guanidine test, that is MIBG scan. And here we use isotope of the iodine, that is iodine 123. This particular MIBG scan it has good sensitivity and as well as specificity as well. Right, it has good sensitivity and as well as the specificity. But this MIBG scan, it is useful for the diagnosis of the adrenal pheochromocytomas. Right, useful for the diagnosis of the adrenal pheochromocytomas. So this is an important point what you should remember. Right, and we have another investigation, that is your FDG PET scan or DOPA PET scan, that is fluorodeoxyglucose right? That is fluorodeoxyglucose positron emission tomography. This is for malignant tumors, right? This is for malignant tumors, that is mainly for the extra-adrenal pheochromocytomas. Right, this is for the extra-adrenal pheochromocytomas. Okay, so for adrenal pheochromocytomas, the best test will be your imaging studies will be your iodine 123 MIBG scan, and for extra-adrenal pheochromocytomas, that is for the malignant tumors, it is the FDG PET scan which is the important investigation. Now you see here we have the treatment part. If you see the treatment, it is the surgical resection of the tumor which is the important line of management. So you have to do complete tumor removal, right? This is the ultimate therapeutic goal. But before doing the complete tumor removal, preoperative patient preparation is important. Okay, it is essential for safe surgery. Now, preoperatively, you have to see that the blood pressure of the individual is adequately maintained. Right, preoperatively, you have to see that the blood pressure of the individual is adequately maintained. And for this, what we give is the alpha adrenergic blockers. Right, we give alpha adrenergic blockers. And what is that alpha adrenergic blockers we give is phenoxybenzamine. This particular phenoxybenzamine, this should be initiated at relatively low doses. Right, relatively low doses. That is, they have to be started at 5 to 10 milligrams orally 3 times per day. Right, 3 times per day. And they should be increased as tolerability increases. Okay, so phenoxybenzamine is the drug what you have to give before the surgery in order to maintain the blood pressure of the individual. Next, now remember, this particular phenoxybenzamine, it has to be given for nearly around 7 days in order to have good blood pressure control. Now the other important thing is, these individuals, they can have paroxysms, that is an abrupt release of epinephrine and norepinephrine. They can have the paroxysms of the blood pressure. So for that, you can give the other alpha blockers, that is oral prazosin or intravenous phentolamine. Right, these are the drugs which should be given for intraoperative paroxysms. Mainly we give IV drip of the intravenous phentolamine. So for intraoperative paroxysms. Next to this particular IV phentolamine drip, if the individual is having intraoperative hypertensive crisis, right, if the individual is having the intraoperative hypertensive crisis, in such clinical scenario, you have to give intravenous nitroglycerin drip. Right, you have to have intravenous nitroglycerin drip. Now you should remember that before surgery, the blood pressure of the individual should be consistently below 160 by 90 millimeters of mercury. Okay, now once the individual has adequate alpha blockade, then you should be able to give the beta blockers. Right, and you have to give non-selective beta blockers that is propranolol of 10 milligrams. Right, it is a non-selective beta blocker. Right, it blocks both beta 1 and as well as the beta 2 receptors. Right, but always remember, first you should give alpha blockers and then you should give beta blockers. Right, never give beta blockers first and then alpha blockers, because once you give beta blockers, what will happen? The entire epinephrine and norepinephrine, whichever is being present, that will go and cause excessive stimulation of the alpha receptors, and that will cause the hypertensive paroxysms where the individual may have even the death as well. Okay. Now, apart from this alpha and as well as beta blockers, what are the other drugs, the other antihypertensives which can be used? The other antihypertensives which can be used in these individuals is, you can give calcium channel blockers, you can give AC inhibitors, that is angiotensin converting enzyme inhibitors, right? They have been used when blood pressure is difficult to control with the phenoxybenzamine. You can use the CCBs and as well as the AC inhibitors, right? And after the adequate control of the blood pressure, you have to do the surgical resection of the tumor. Now, there is one important multiple choice question regarding the surgical resection. Remember, surgery is contraindicated right? It is contraindicated in case of malignant pheochromocytoma. Right? Contraindicated in case of malignant pheochromocytoma. Alright. So, in case of this malignant pheochromocytoma, you have to give chemotherapy. So, what is that chemotherapeutic drug we give is, that is met-tyrosine. This will be the multiple choice question here. So, it is your met-tyrosine what is given in patients with a malignant pheochromocytoma. This particular met-tyrosine, the mechanism of action is, it will inhibit the catecholamine production. Right, it will inhibit the catecholamine production. So, this is the important point regarding your treatment of pheochromocytoma. Right. Now, if you see some more questions related to pheochromocytoma, so the dose of clonidine in the suppression test done for pheochromocytoma is 0.3 milligrams. So, this we have discussed. And you take the investigation of choice in pheochromocytoma, it is your urinary catecholamines. Now, all of the following are increased in pheochromocytoma except vanillyl mandelic acid, metanephrines, 5-hydroxyindolestic acid and as well as the catecholamines. So, what is that substance which is increased in pheochromocytoma? Which is not increased except, that is your 5-hydroxyindolestic acid. 5-hydroxyindolestic acid is your serotonin. It is increased in case of carcinoid tumors. The remaining all substances can be increased in patients with a pheochromocytoma. So, the answer here is C, 5-hydroxyindolestic acid. Next, all of the following are the features of the pheochromocytoma except hypertensive paroxysms. Yes, there can be present. Headache can be there. It is the most common symptom. Orthostatic hypotension can be present because of the plasma volume reduction, and wheezing will not be the feature of the pheochromocytoma, right? Because it has no effect over the respiratory system. And most common symptom of the pheochromocytoma, what did we discuss? It is the headache, which is the most common symptom, and the most common sign is your hypertension. Next, all of the following, okay. So, this completes the discussion on the pheochromocytoma. So, I will shortly revise. Remember, pheochromocytoma predominantly secretes norepinephrine. Extra-adrenal pheochromocytomas, they are called paragangliomas. The most common site for extra-adrenal pheochromocytoma is your organ of Zucker candle. And if you take the clinical features, the most common, the clinical feature here is headache. The most common sign is hypertension. Cardiovascular system, these individuals, they can have arrhythmias, they can have angina or MI in the absence of the coronary artery disease. And these individuals, they'll have profuse sweating as well, right, because of excessive increase in metabolic rate, basal metabolic rate. And these individuals, the blood glucose levels are increased because of excessive glycogenolysis and as well as the anti-insulin action. Next, the other important clinical features is these individuals, they will have orthostatic hypotension and as well as the increase in the hematocrit. The investigation of choice is urinary metanephrin, that is a screening test, and you take the confirmatory test, that is by your plasma metanephrin increase, right? Normal vanillin malic acid, it is less than 6 milligrams per 24 hours in the urine, and in case of an individual with the pheochromocytoma, it will be more than 6 milligrams per 24 hours. Now once you do the chemical analysis, you have to do the imaging studies. For adrenal pheochromocytomas, the best test will be your MIBG scan. But for extra-adrenal pheochromocytomas, that is paragangliomas, the best test will be your PET scan, that is FDG PET scan, that is fluorodeoxyglucose positron emission tomography. And whenever the increase in the plasma metanephrins, if it is more than 4 folds, then pheochromocytoma is confirmed. If the increase in less than 4-fold, then you have to do clonidine suppression test, and the dosage is 0.3 milligrams. And if you take the treatment, the surgical resection of the tumor is a treatment of choice. But before that, you have to do preoperative assessment where the blood pressure has to be controlled between 160 by 90. And you can do this by phenoxybenzamine, right? And intraoperatively, in order to prevent the paroxysms, you have to give phentolamine drip. And the other oral drug what you can give is prazosin. And after doing adequate alpha blockade, you have to do the beta blockade by your non-selective beta blocker, that is propranolol. But for malignant pheochromocytoma, you should not do surgical resection. For malignant pheochromocytoma, remember what is the treatment is you have to give antineoplastic drug, that is medtyrosine. Medtyrosine will inhibit the catecholamine production. So this completes the discussion on pheochromocytoma.